figure out why that was. And it's because you have things called buttresses in your face. A buttress is an arch that's very, very strong. So the strong parts don't break. You break around the strong parts. You know, when you build a bridge, you have all those stones that are a little bit slanted, so the stones come into an arch, and when you put that top stone in, the capstone, it makes the arch very, very strong. So it's hard to break an arch. So you always break around the arches in your face. There's a bunch of arches there. As you guys would expect, males have way, way more facial trauma than females. Males are stupid. They do stupid things. Right? They get assaulted. They get into fights. They play sports that are stupid without helmets on. Usually late 20s, late 30s, that's when the males are the stupidest during their later years. A lot of these are car-related fractures. It takes a lot of force to break your face. You don't break your face normally from just falling down from standing. You need a decent amount of force to break it. So being in a car at 20, 30, 40 miles an hour and having your face thrust against the steering wheel, the windshield, out the door, against the buttress of a bridge, that's when you're going to actually do the most damage. And then as you expect, summer months, that's when you're outside doing stupid things like drinking and playing sports without a helmet. So the face is important, all right? There's a lot of things in your face that are very, very important to your life. Your self-image is important. Your airway is there. If your airway gets clogged, and I want to tell you guys that I put pictures of the residents in. I asked permission last night at midnight of every single one that's in there, so they all knew it was coming. Your airway is there. If your airway gets occluded or disrupted, it's going to cause big problems to you, and you have to manage the airway. So managing a bloody airway in your face is very, very difficult. Your face is very, very vascular. I'm sure the surgeons can tell you, although I think they all left, that there's a lot of vessels that bleed in your face. If you cut your face, it can bleed like crazy, especially your scalp. All your senses, except for one, are in your face. Taste, touch, vision, hearing. They're all in this area, and they're all very compact in a small area. So it's easy to damage multiple senses at one time. Of course, face is also for my retirement. For those of you guys who don't know, I was married to an oral surgeon for a little while. She was going to make a lot of money, and I was going to retire early. And then she divorced me, so that didn't work out very well. So mechanisms are very, very important, all right? Are you hit by a baseball bat, or are you hit by a car? The force of those two things is very, very different, all right? Do you have LOC? If you have enough power to make you lose consciousness, then there's enough energy transmitted to you to make you also have a bleed inside your brain. Have you been drinking? If your sensorium is altered by a lot of alcohol, then maybe it's not the alcohol that's doing it, maybe it's because you have a traumatic brain injury. So it's very, very hard to tell, so alcohol really clouds it. Do you have vision problems? On top of fracturing the bones in your face, did you also rupture the globe in your eye? And can you not see because of that? You need to figure that out. And then of course, hearing, tinnitus. You need occlusion of your teeth. This is a good question to ask about, because if you can't bite, you can't take in food, you can't get nutrition, you're going to do badly. All right? And then facial numbness, facial tingling. You guys may have noticed that a lot of the nerves in your face run through these little canals, and that happens to be where the face is weakest, because there's little canals in there. That's where you're going to break. So if you break where there's a nerve, the bones will shear off the nerve and make you numb. And then always think about abuse. People who have weird injuries, people who have stuff like bruises on the face that you don't expect, think about abuse, especially in children, especially in women. Think about people getting injured on purposeful trauma. So let's talk about mechanism. Blunt mechanism we see quite a bit of, right? Beer bottles to the face. I know all cab drivers carry a baseball bat because it's legal. You're just going to baseball practice, but really you just want to beat up the guys who don't pay you. I can't tell you how many times I've seen this now. So being hit by a baseball bat is very different from being hit by a car. Right? It's going to cause much different injuries. Car accidents, again, a lot of energy being transmitted from the car accident to your body. The more energy that's transmitted to you, the more chance you have of disrupting your tissues. Altercations, we see a ton of fights in our neighborhood, a ton of assaults. And then falls from height. The higher up you go, the more likely you are to fall and break something. We have a lot of people in our neighborhood who do stuff with machinery. So getting parts of your body stuck in the machinery, getting your hair stuck, and getting pulled into a machine. That will definitely disrupt parts of your face. And then penetrating injury, gunshot wounds versus stab wounds. Think about the mechanism and what kind of cavities will be created. A bullet going through your face is going to cause a little little primary cavity, but all the energy from the bullet is transmitted to your body if it stays in your body, and all that energy's got to go someplace. So it's dissipated in the tissues of your body. So there might be a little hole where it went through, but all the tissue around it is also eventually going to die. And then explosions, we don't see that many, luckily, but there are many, many ways explosions can disrupt your tissues and break parts of your body. If you look at the face, there's different parts that are easier to break than others. Right? Your nasal bone and your zygoma, those are pretty easy to break. They're little fine bones, and they're pretty easy to snap off. As opposed to the frontal bone, the glabella, that's really hard. It's reinforced bone. It's a nice big fat buttress. It's really, really hard to snap. So think about how fragile the bones are and how much energy it takes to actually break something in your face. If you have a little nasal bone fracture, then maybe you probably don't have another injury. But if you've broken the frontal bone in your forehead, it takes a tremendous amount of energy to do that. So you should be scanning every one of those guys' brain to look to see if they have a brain injury as well. When you're examining somebody, you're going to look for asymmetry, all right? I like to look down from the top of the bed. This is how all my oral surgery friends and ex-wife told me how to do it. So you look down from the top, and you compare left to right. Your face should be symmetric on both sides, all right? You want to look for open wounds. I can't tell you how many times I see face or head CTs that have rocks in the skin. Everybody always looks inside the calvarium, inside the skull for injuries, but they don't look outside for foreign bodies. Those foreign bodies, you got to get them out of there. They're going to cause abscesses, right? And then obviously you got to do a good nerve exam, look for your cranial nerves, and then your eyes, nose, and mandible should be palpated as well. This is a guy that we saw many, many years ago now, back in the old C building, who was riding a motorcycle without a helmet, and he hit some wet leaves and spun out, and his face got dragged across the ground, and that's actually, that right there is his upper lip that's pulled off and pulled around his face. This guy did really well. ENT spent like 6 hours in the operating room, closing him up with like 600 stitches. So how do you do a physical exam of the face? I think it's really important to follow the same pattern every time so you don't miss stuff. You don't have to do it the same way I do it, but that's the way I learned it, so that's the way I do it. You want to start on the upper outer orbital rim. Now palpate both sides at once and go across the orbital rim to the nasal bone. Go down the nasal bone, and you're feeling for crepitus, you're feeling for bones to move, you're feeling for air into the skin, you're feeling for step-offs. Go down the nose, go to the inferior orbital rim, continue in the same direction, go down the zygoma, come down the outside of the mouth, across the bottom to the mental protuberance of the chin, and then you're going to feel inside the mouth. You're going to feel the bottom teeth and then the upper teeth. And if you follow this pattern every single time, you'll pick up a lot of fractures. You don't have to wait for CAT scan to tell you they're there. All right? But you have to do a good physical exam to pick stuff up. The last thing you're going to do is grab the upper teeth and pull outwards. People with Lefort fractures, their whole face will slide out. Now, we had a Lefort fracture a few nights ago, combination 1-2. We'll talk about that in a little bit. Your neuro exam, I'm sure you guys all know this already because you do such good jobs on neuro and you learn to do each cranial nerve. I encourage you guys to do every single cranial nerve when you see these trauma patients that have facial injuries. When you're looking at the eyes, you want to look for subconjunctival hemorrhage. Make sure it doesn't cross the limbus into the center of the eye. Right? Look for directional diplopia. If you ask them to look up and then it gets blurry, then maybe they have entrapment of one of the inferior rectus muscles. All right? Make sure their eyes are yoked together. You guys remember that the yoke is the thing that holds the two oxen together, so when they pull the plow, it pulls straight. If their eyes are not yoked and they're going in different directions, then maybe they're stuck, maybe they're entrapped, or maybe they're just really, really, really drunk, because I've seen disconjugate gaze from people who are really, really drunk. People with raccoon eyes, they have black eyes on both sides. This is often due to fractures because the blood starts to pool down and it gets stuck at the bottom of the orbits, and that's where it pools. And the skin is very thin there, so you can see it there very well. Look for the eyes to be reactive and have normal pupils. Look for globe ruptures. Anytime the pupil is not round, you should think that they have a globe rupture. Then exophthalmos and enophthalmos. If their eyes are sticking out, maybe it's because they have too much blood behind it and it's pushing them. If their eyes have fallen backwards, then maybe their orbit is broken. Remember that the orbit is a bony box with the globe and fat and some stuff inside it. If you change the contents of the box, like you put blood in it, the eyes will come out. If you break the box and make it bigger, then the volume is bigger, but things inside are the same, it'll fall backwards, especially when they're laying down backwards. So look for the position of their globes in their eye. And then always check visual acuity. You want to make sure that they can see. For the nose, you want to make sure that you look at where the bridge of the nose is. Remember, the medial canthus of the eye is attached to the nose bones. So if the nose bones are broken, the eyes will spread outwards. This is really important because the way the muscles attach, if you change the size of the bony box, the muscles won't pull correctly and they won't be able to move the eyes correctly. Telecanthus is when the bones are spread out and moved to the sides. There's difference in sizes to know for males and females. I don't think you guys have to know it. Just palpate the bones and see if they're in the right spot, see if they're where they belong. Make sure you always check for septal hematomas. If you miss it, then the cartilage is going to die and end up with what's called the saddle deformity. When a cartilage dies, the bridge of the nose sort of caves in and then it disfigures that face. And then look for rhinorrhea. You have to think about what's causing the rhinorrhea. We'll talk about that in a little bit. The mandible, you want to look for occlusion. The teeth should line up correctly. I always ask the patients, when you bite down, do you feel like your teeth are lining up? It's really, really important. You want to palpate the different parts of it. Start with the condyle, which is right in front of the tragus of the ear. All right, and then go down and feel towards the middle. Remember, your mandible is attached to the skull and it forms a ring. You can only break a ring in two places 99% of the time. So if you have one fracture, you should always look for a second fracture. The time that doesn't happen is when you land on something right in the middle and you kind of split the mandible open and it just hinges open because the jaw hinges on the TMJ and that can open up by itself. So that's the one time you may see only a single fracture in the mandible. So case one is a 48-year-old male. He was in an active shooter drill at downstate and this nice young lady was playing their drill and got a little over anxious and was overacting and strikes the male with the butt of the gun in the face. The male is spitting out blood and teeth and there's no positive LC, there's no other trauma except for that one strike. So what is the workup you guys are going to do for a single strike to the face? What would you guys do? Olu, what would you do? Excellent, physical exam, I like that. Is that it?
I mean, depending on what the exam shows, I may get a facial policy.
Okay, that's fair. So you always want to evaluate ABC, right? You guys are ER docs. Whenever somebody asks what's the first thing you do, you should automatically say ABC no matter what it is. A good physical, like Olu said. And then probably going to get mandible films or a CT, depending on what their mandible looks like. And then you always want to look, if there are teeth missing, you have to find those teeth. The teeth go someplace. So if you get them down into your lungs, those teeth are covered in saliva, they're going to lead to infections. So you got to make sure you account for every single tooth that you can't find. This is what the mouth looks like. All right, so what do you think, Olu? Looks good, looks not so good? Not so good, I agree with you. So these are alveolar fractures. I don't think he's got a mandible fracture because the whole mandible is not moved over. Just these teeth have moved in what we call en bloc. The alveolar bone is the part of bone that holds the teeth. So only the top part of the bone is broken, not the full entire mandible. Right? So again, it's the part that holds the teeth. You'll be able to tell because many teeth will be moved as a block or en bloc, what they call it. You can go in, you can come out. It's more likely in because you're most likely getting hit from the front and pushing backwards. But teeth can be luxated, which means they're loose. You need to secure them in place. What you don't want is the patient getting intubated with a loose tooth and then going to the SICU, going to the OR, and then it falls out and then you don't know where it went. So if the teeth are loose to start with, you have to make sure they're secured in place and don't move. Right? Again, you have to account for all of them. Remember that teeth can come out of your mouth, they can move around, but they also can be pushed up and have what's called intrusion. Right? This is intrusion, where they were hit and the tooth went up into the sinuses. So you have to make sure you account for every single tooth. You can't just say, well, I don't see it, I'm not sure where it is. Because if it's in the sinuses, again, it's a saliva-covered object, it's going to lead to infections. Some terminology for you guys to know. When a tooth is painful but not loose after trauma, it's a concussion. This happens because the dental ligaments that hold the tooth in place have been partially torn but not fully. All right? When you have subluxation, they're loose but they're not displaced. So you can wiggle them around but they're in the right spot. Intrusive luxation is when it goes in, extrusive is when it comes out, and exarticulation is when it's totally out of the mouth. You spit them out or swallow them or aspirate. So what do you do with the tooth that you find? How do you carry it around? You don't put it in your pocket, right? So ideally you want to put it in something that's going to keep it from dying because those dental ligaments, if you're going to reattach it, you have to keep them healthy. They say use Hank's balanced salt solution, a saber tooth container. So I've been working for a couple years here now, Everybody says they exist, but I've never seen one. Dental's never seen one. The best thing to do is put it in a cup, rinse it off with just quick water, running water. If you have saline at home, that's great, but rinse it off with water in the street, and then put it in either a glass of milk, or if the patient's awake and not altered, you can just have them hold it in their mouth and in their cheek. That's the best environment for it. That's where it actually came from. But that's not for the patients who are unconscious. If you even have some minimal depression of consciousness, I don't think you should put a foreign body in their mouth for them to hold. Right? They have to be awake to do that.
Question?
Yep.
Contact lens solution. Kind of saving.
I've never heard it done before. It seems like it would work, but I've just never heard of it. I'm not sure. Remember, contact solutions have a lot of stuff in there besides water and besides salt. There's oils in there to lubricate your eye. So I'm not sure if getting oil on the dental ligaments is going to be helpful. So I'm going to say I don't know for now. My gut feeling is probably not, just because there's enzymes in there and other stuff, but I don't know the answer to it. And then if you leave it dry, or if you buff it off with a rag and clean it, then most likely when you reimplant them, it's definitely not going to take. So you don't want to do that. So you have to think about a tooth if it's mature or not if you're going to reimplant it. Right? If you're an older person and the tooth comes out, chances are the root, the canal it goes through is very small, very tight, and that nerve is never going to grow back. Those guys are going to need implants. But if you're a young person, your teens, early 20s, maybe you have a chance. If you're a kid, it's definitely better. But if that tooth is mature and the canal is small, it's not going to take, it's not going to go back. If you do want to put it in, there's this one study I read out of Britain that said take Fosmax, dissolve a pill in water, and then put the tooth in there. For some reason, they have better reimplantation rates. You can also use doxycycline. They also have better rates with that. But again, if it's out of your mouth for more than 20 minutes, chances are it's not going to take, it's not going to hold. What you want to do is you want to put it back in the socket. I usually numb them up with lidocaine, either do a mental, an inferior alveolar block for the bottom teeth, and then a local block for the upper. Block them so it doesn't hurt. Put the tooth in the socket as gently as you can, and then have them bite down on the gauze to push it back up into place. All right? It's usually hard to push it back up yourself, especially when it's further posterior. So just let them bite down on something and it'll push it back up where it belongs. And then splint them with a figure of 8, where you can put wires on it if you're real ambitious. The teeth have to be stabilized, otherwise they're going to keep moving around, or they may fall back out. So just take like a 2-0 silk, and just go around the tooth in front of it, around the tooth, and around the tooth behind it, and make a figure of 8, probably with 2 or 3 throws, and then tie it, and that should hold it there. You can use arch bars, which are pretty complex to put on. I don't recommend you waste your time doing it. Plates are definitely for the oral surgeons. But if you want, just take Dermabond and put a wire across there, a nichrome wire, and just put some Dermabond on it and let it heal. It's real easy to scrape Dermabond off a tooth by the dentist the next day. I wouldn't worry too much about that. Salt water rinses when they go home. They should probably go on antibiotics. Their canal is open, their roots are exposed. Definitely analgesics and a soft diet, and then just follow up with Omavest the next day if you work in a place that doesn't have consults 24/7. Again, splinting, this is how to do with a paste, but you can do it with Dermabond as well. So fractures, I think you guys need to know the names of them just because they're going to be on your in-service. There's Ellis 1, 2, and 3. However, if you talk to oral surgeons, they never use that terminology. That's an ER terminology. They say either root or crown fractures. They don't call it Ellis 1, 2, and 3. In Ellis 1s, it just goes through the dentin part of the tooth. There's no bleeding, it's not red, it's usually not painful. For Ellis 2s, it goes down into the dentin, but it doesn't cut through to the root canal. And it usually looks red, but it won't bleed. And then in 3s, it actually goes into the pulp cavity, and they bleed. The 3s have to be closed off. The 2s should probably be capped also. And the 1s you don't have to do anything with, just put a little Dermabond on it to make sure it doesn't cut your gums if you are worried about it, right? They say you can cover with glass ioner, cement, or calcium hydroxide. I've never seen this stuff in the ED. I know Downstate has a tooth box someplace where they supposedly have all this stuff. I've just never used it, never seen it. These guys can all go home on antibiotics and then follow up with Omavest the next day. They definitely need analgesics for the class 2s and class 3s when the root is involved. All right, case 2 is a young gentleman who's sitting on top of an E, and he's very drunk. He falls off. He hits his face in the middle of the E on the way down. He has positive LOC. He has epistaxis, and he's born of EMS, sort of crying. So here's what his physical exam looks like. The bridge of the nose is tender. It looks a little bit out of place. He has some crepitus. There's a little lack on the top of the nose. And he has blood coming out of his nose. There's no septal hematoma. But he has this clear fluid coming out. And you're not sure what it is. So how would you guys figure it out? You're obviously worried, is it tears or is it CSF? What would you do? I don't think I would taste it. I think that all secretions of the body taste the same, salty. So you can drop it on a tissue and see if you get the halo sign. I don't admit I've done this a couple dozen times by now. It all looks the same to me, I'm not sure. So I'll use glucometer. Most secretions from your body don't have glucose on them. So if it's sweat or you're crying, it won't have glucose in it. Because you don't want glucose on your skin for bacteria to proliferate. However, your CSF, that has glucose in it. You guys all know that. So if it registers anything above like 10 or 15 on the glucometer, you should think that it's CSF. So workup for case 2. You do your ABCs, you do it good HB. You get a head CT because they have positive LOC. They're drunk, so you can't clear them by nexus. You got to do a cervical spine too. Since you're going to do the head and the neck, you can scan their face while you're at it. All right. Some people may want to just use plain films, but it's probably easier just to scan them. You get your face consult, whoever's consulting on face today, whether it's ENT, ophthalmology, or oral surgery. And then you can do your primary closure of that cut and then update your tetanus. So here's your first film that you get. What do you guys see? Right, everybody sees the nice nasal fracture going across. If you were to CT it, it would look like this, broken straight across and a little bit pushed over to the side, a little bit translated. So the nasal bone is the most easily broken bone in the face. It's very thin, it sticks out of your body. The things that stick out are the easiest to be assaulted onto. The thing is you can't miss the NOE. A nasal-orbital ethmoidal fracture is a much worse fracture than just a nasal bone fracture. We'll talk about it in a second. But when you have NOEs, they often will have a CSF leak because the whole center of your face is sort of collapsed in. They'll all have swelling and tenderness. You may have some telecanthus. You may have epistaxis because the nasal mucosa is going to be torn as well. And then radiographs. If it's just a simple nasal bone fracture and it's not displaced, you don't really need x-rays, but you have to be sure it's nothing worse like an NOE. So here's what an NOE looks like. It's nasal, orbital, ethmoidal. The whole center of your face is kind of collapsed in. So you have some force that hits you in the middle and just goes forward and smashes everything in there. These are really bad fractures. Your cribriform plate is there, it leads up to your brain. There's a whole bunch of stuff in there you really don't want to break. There's a lot of CSF coming out because you've disrupted the bridge between the brain and the outside, but sometimes there's clots on it, so it may not leak initially. I saw a patient many years ago who came in after some trauma about a year later and said, "Doc, whenever I put my head forward, my nose runs." And I was like, all right, maybe I'll post it, maybe say, something weird. Let me see, can you do it now? So she put her head forward and it just started dripping, bloop, bloop, bloop. And we tested it, it was CSF. It turns out that person had a fracture and then got mucor in there, which destroyed all the bones around it, and then she had a big hole between her brain and the outside of her body. Luckily, she didn't have meningitis. I don't know how, but she was lucky about it. Remember that the medial cantilevers of your eye are attached to the nasal bone, so if the nasal bone is broken, the part that holds your medial orbits in your eyes are going to be pulled out. You'll have telecanthus. The lacrimal apparatus is all there, so if you can't drain tears out of the front of your globes, then they got to go someplace. They're probably going to pool and come out of your eye. Right? That's called the epiphora. And then you can also obstruct your sinus drainages too, so you have a high chance of getting sinus infections. This is not the correct way to collect CSF. Usually you want to look for a dural tear when they have these injuries. It may be a delayed finding, like I said. If they have a clot there, it's going to clot it off and then come out later. If your glucose is over 45, some say even 20 or even lower, but if it's over 45, it's almost definitely CSF and non-nasal secretions, right? Like you said, it has a salty taste. Thank you, Adam. And if it forms rings on a tissue, those are other ways to do it. One thing I read, it will not stiffen a handkerchief. I'm not sure what that actually means. Nobody carries a handkerchief anymore. But again, if it's open, you have a risk of meningitis. These guys should all get prophylactic antibiotics. So case 3 is a construction worker. He's hit in the face with a steel girder. That's a big, huge object, a lot of mass. He has no LFC, but it's painful to open his mouth. He has trismus. His face just looks unequal to you. So what kind of workup do you want to do? Pete, what would you do? He's hit in the face with a steel girder. Excellent. Right after you do your ABCs, your HP. Now you guys want to see everything? So you have a high suspicion for a fracture, so you want to do your facial films. You can do a CT also, you wouldn't be wrong. But you probably want to clear a C-spine if he's hit with that big a mass. You want to make sure that he doesn't have a spine injury as well. Here's your first film. Pete, what do you think? This is your jug handle view where your head is tipped back. You're looking mostly at the zygomatic arches.
Yes.
Yeah, the arch is disrupted, right? So typically an arch breaks in two places also. It's a ring just like anything else. So you're gonna get this classic W fracture, where the middle of the W is pushed in. The problem is that the things under the W are your muscles of mastication. So when that bony prominence is pushing against the jaw muscles, the thing that move your jaw, you won't be able to open and close your mouth. So you'll have trisms, all right? So when they're depressed, they have to go to the operating room to fix them. Otherwise, they're gonna stay like that and they won't be able to chew later on. So if you have a depressed ring fracture or a depressed arch fracture, they have to go to the operating room. If they're not depressed, then they can probably get away with doing nothing. But if it's depressed, you gotta pop it out and then plate it, fix it, and put it back. So again, when you have a broken arch, usually just need OMFS follow-up unless they're depressed and you have to go to that room right away. Diet restrictions, they won't be able to chew, so make sure they get their nutrition through a straw. Definitely a lot of analgesics, and then if it was a strong enough force to break the arch, you might want to think about getting a trauma consult as well. All right, case 4 is a 20-year-old man who likes to pose for photos while he's out climbing. He falls down because he's not paying attention, he lands right in his face. He has no LLC, but he is complaining of jaw pain. He says he can't talk now. Physical exam, he has trismus. You do your tongue depressor test, and it's poor. You guys all know if you put a tongue depressor between the teeth, ask them to clamp down and turn it. If you can break the tongue depressor or they can hold it, then they do not have a jaw fracture. It's actually a pretty reliable test. But if they can't hold it and you twist it and you can pull it out, then there's a high chance they have a fracture. All right? There's blood coming around tooth 26, 27. You guys all remember how to number the teeth? Top to bottom, right to left. So there is 3 molars, 2 premolars, that's 5, a canine is 6, and 2 incisors at 8. So there's 8 teeth in a quadrant. So 1 is up here on the top right, 8 is your incisor on the right, 9 is your incisor on the left, and then 16, 17, and 24. 32, sorry. All right? So that's the lack he has. You can see that there's blood coming out between the teeth. That's a dead giveaway that they have a mandible fracture. So here are your films. You guys know that it doesn't break in only one spot. So you suspect that one in the front, but then you have to find that one in the back as well. So 43% of mandible fractures occur in car accidents. Remember, these are high-speed, high-energy accidents. Your face is striking the steering wheel, the dashboard, the window. These are all immovable objects, and something's got to give. It's usually going to be your face. And your jaw is what you lead with. Especially if you're in a seatbelt that's restraining your shoulders, your head comes forward and it's going to hit your jaw and hit your nose. All right? This is the order of commonness. The body is most common. That's been an in-service question before, which one is most common. So just try and remember this is the body. So let's talk a little about terminology, because I'd like you guys to sound smart when you call your consults. A simple fracture is a closed fracture. It's not open. A compound fracture is open. Comminuted is many pieces. A green stick fracture usually happens in kids where only one side of the cortex is broken, but not the other side. Pathologic fractures usually happen due to tumors that either start in bone, like multiple myeloma, or metastasize the bone. Remember the tumors that met? The mnemonic, Dr. Lucchese's mnemonic is lead kettle. The symbol for lead is PV. So prostate and breast can be either lytic or blastic. And then kettle, KTL, is kidney, thyroid, and lung. Those are the ones that go to bone. Often you'll have multiple fractures, more than one, and they can be impacted or pushed together. The teeth can be pushed in. And you can also have indirect fractures. If you land on your mental prominence, you can snap off the condyles in the back. So always be curious when they have an injury to the front, but they have pain in the back. Always investigate and see what's back there. This is a little bit about stuff from oral surgery. Probably not so important for you guys, but I throw it up there. Knowledge is never bad. A favorable fracture closes up when the muscles pull on. So you can hear that it's going this way, and the masticated muscle will pull it closed. As opposed to this fracture on this side, it's unfavorable. When the masticated muscles pull, they'll open the fracture up. All unfavorable fractures have to go and get closed up with a plate to hold them together. So again, they happen in two places almost always. If their occlusion is changed, it's almost always going to be a fracture. If they have V3 anesthesia, right, that's because it broke through the jaw and the mental nerve is traveling in there. It cut the mental nerve. These guys will need frequent suctioning because they bleed into their mouth a lot. And the Panorex is the best view, but I don't really want to send these patients over to oral surgery land because they're unstable. They may lose their airway, they may crash. So while it's the best view, they're probably not going to get it. Like pizza, we're probably just going to do a CT, right? Non-unions in the mandible are very rare because it has a good blood flow. So on physical exam, the occlusal surfaces will be stepped off, meaning as you look at the teeth, there'll be one layer, and then there'll be a step and another layer. So that's a good sign to have a mandible fracture. Of course, if there's bleeding between the teeth, that's also a good sign, like this, where the gums are torn. Right? If it's asymmetrical, if the teeth move, usually it's because the socket is broken. It could be either an alveolar fracture or a full mandible fracture. If the mandible is tender when you tap on the teeth with a tongue depressor, a lot of times you see these periorbital hematomas down here in the bottom, in the reflection, you'll see big hematomas there. It's also a sign as a fracture. If they have trismus where they can't open, and condyle fractures, often if they have blood in their meatus, in the back, condyle fractures, there'll be another tip off that it's back. Stabilize them. You want to bind the lower and upper teeth together. If you're out in a hospital that doesn't have a lot of consultants, you can do it pretty easily. Just take that nichrome wire, make it into a loop, push the loop between two teeth, split the parts of the loop around, and put it through teeth next to it. It's really easy to do. And then you're left with a good anchor. You can tie the two of them together. And if any of you guys want to learn how to do it, I'm going to show you outside the lecture. If you have no teeth, it's really hard to stabilize these people because there's nothing to tie them to. So these guys have either what's called gunning splints, where you have like a denture that goes in their mouth, it's just a tray, and it pulls them together, or you can actually just drill screws into their alveolar bone and wire them together. But these are all like if you're in a place that doesn't have oral surgery, doesn't have dentists, and you need to stabilize. Treatment for us, you want to put them in a Barton's bandage that's going to hold their mouth closed and keep them from moving. It just makes their life easier because they don't have pain when they move. They should get antibiotics because it's an open fracture in the oral cavity that's contaminated with saliva. They definitely need analgesics and a soft diet. If they can't eat, they're going to need some sort of substance. This is more for admitted patients though. And again, if they're edentulous, they're almost all going to need to be plated. Right? They go home, they just come back the next day. We see a lot of jaw dislocations, and some of them are pretty easy to get back, but then some of them are pretty hard. There's a lot of things in the literature here that we see can cause them. Singing, yawning, seizures, trauma, all these weird things. I think eating apples cause a lot of jaw dislocations. If you have it once, chances are you either have stretched out the ligaments or you have a small cartilage there to start with or a small head to your condyle, so they're going to happen again. Again, ligament laxity, people with Marfan's, they happen often in these people, but if it happens once, chances are it's going to happen again. So almost all jaw dislocations are anterior. It's really hard to go posterior because remember the fossa for the mandible is right in front of the TM and the canal. So if it goes backwards, it's got to go into the ear canal. It's really hard to get in there. You got to smash the bones to get in there. So they almost all come out backwards. So to put them back in, you push them backwards. All right? We'll talk a little about how to get them back in. On exam, they can't close either active or passively. If you push their mouth up and they can't close, that's a good sign they have it. They have trismus, they have this tilted jaw where it's over to the side, and they're very tender back in the condyles in the back of their head. When you go to put them back in, you're going to be pushing backwards. If you're pushing against something that's painful, they're just going to kind of run away from you. So you need to stabilize them against something. The way I learned to do it is put them in a chair and sit them up against the wall, and then you can push backwards against the wall. You can also have them in a stretcher. You can set the stretcher up and push back against the stretcher. You could have them laying down and push backwards against the back of the stretcher that way. I find the chair is probably the easiest way to do it. But remember that there's a fossa and then a hump, and they get stuck in front of that hump. So you got to bring them down and then back. So the way I was taught to do it is wrap your fingers in gauze, because when you release them, they're going to snap closed. You don't want to get bitten. So put gauze around your fingers, and then you're going to pull down, a drop towards you, and then backwards. And that's the way to get them back in. If they have bilateral dislocations, Do one side at a time. Don't try to do both at the same time. You'll never get them back in. And then once you get them back in, they get a Barton's bandage. They can go home the next day and follow up with home effects. As you get dislocations, you can also fracture them while you're reducing them, so be careful you don't put too much force on them. The condyles are a little bit easier to break off in the middle of the jaw, so just be wary of that. If it's an open fracture or the TMJ is open, you can get osteo in there and you can destroy the joint. I've seen cases where they get dislocations and they have a lot of swelling, and it's not that many, but they get the swelling and they compromise their airway, so just be wary of it. If you get a case like that, you can write it up too. And then a lot of stuff is back there, the carotid, the facial nerve is in there, so just be careful of that stuff. Look for signs of injuries to those things. All right, case 5 is a third stroke died in a high-speed MBA. He's got alcohol in breath, he's got positive LC. He shattered the window because he wasn't wearing a seatbelt. This is what his face looks like. So you get your AP view of his face on X-ray, and it looks asymmetrical to you. This side definitely looks more white than this side does, right? There's more density there. You get your Watersville, your head tip backwards, and again, you have that asymmetry. But you also see that there is some lucencies here, here, and here in 3 places on the cheek. That's a common fracture pattern, right? That's your tripod fractures, right? They're also called mail-out process. Your cheek is your mail-out process, right? So the common fracture of the zygoma, again, is a W fracture, and then you have one through the sinuses, and then one posterior also through the orbits. If you see air fluid level in the sinuses, that's a pretty good indication that there's a fracture there. So again, it's the ZMC, the zygomatic maxillary complex fracture. This part of your face, your cheek, is kind of just taken off, right? This is a very, very strong bone, but the bones around it are very, very weak. That's why you break in the same spot every single time. You want to look at it from above and make sure it's not translated. If it's translated and moved, it has to be fixed operatively and put back in place. Because you don't want to leave the person with an asymmetrical face. They're going to look different, right? When you have these fractures, it's a lot of force right here to your face, but what's right there? Your globe is right there, your eyes are there. It usually breaks inferiorly through the orbit, so it goes through the V2 nerve, so you can often tear that nerve. So you'll have numbness on the face. If you have numbness on the cheek, that's a good sign they have zygoma fracture, right? They have anophthalmos, because you've broken the bony walls of the orbit size is bigger, so the eye falls backward. And then epistaxis, intraoral hemorrhage, and trismus, and then of course subacute air. There's air in your sinuses. If you get a fracture there, it's going to leak out into your face. Here's a nice CT recon showing 1, 2, and 3. The 3 areas where you're fractured. That's why it's called tripod. Right? So these guys should all get OMFS consults. It could be nothing, or it could be an open fracture. It's all depending on how much force is there. Right? They have a lot of cosmetic problems with their faces shifted. You can get globe problems as well. When you send them home with sinus precautions. Their sinuses are broken, so if you sneeze, all the air is going to come out of their sinuses into their face. They should get antibiotics because the sinuses are ruptured. They definitely not found analgesics. And if there's any worry at all of the globe being injured, ophthalmologists see them and look for globe injuries. All right, case 6. You have a 35-year-old vegetarian who's on the trapeze on the West Side Highway. You guys have all seen the trapeze school there. He misses the bar and it hits him in the eye. He plummets to the net, but luckily for him, there's no LOC. He does have pain with eye motion though. All right? One of us was really lucky enough to catch Dr. Gore up there on the West Side Highway. So, on general, he was malnutrition because he's a vegetarian. His legs are exactly they're gone now. He has no rim step off. By the way, Dr. Gore has seen this lecture before. He approves of all these slides. He has his periorbital hematoma. His cranial nerve exam, his cheek is numb. He has double vision, especially an upwards gaze. And then his TMs are clear. So what's your workup for this case? You want to do your APCs with a B as a B12 level. His neck is cleared by nexus. He's not drunk, he doesn't have any tenderness. You get your facial films, your CT facial bones. And because it's hitting the eye, you probably want to get an ophtho consult. I don't think I'm going to call neuro because of facial numbness. Here's what his films look like. All right, you guys again see this asymmetry of both sides. But here, it's not the whole sinuses that's whited out. It's only one little part of it. Right? It's only that little part up there. All right, so it looks like a teardrop hanging down. That's called a teardrop sign. This happens when you have an orbital floor fracture, but it doesn't rupture the sinus's membrane. So the blood from the orbit just hangs down and forms what's called a teardrop sign. You usually have this trap door, and depending on how big it is and how much swelling there is in the orbit, it may or may not push the muscles down into the trap door and get entrapped. So there's different theories about how this happens, all right? First of all, it's the weakest part of the eye, the floor, and the medial part, lamina propria. There's the hydraulic theory where something hits you in the front and it pushes your globe backwards, and by hydraulic pressure, it raises all the pressure inside the orbit. The other is when the bottom rim is hit. The rim is very strong, but it buckles inwards, and then the floor buckles down because the rim holds. Nobody knows what's really true. It's probably a combination of both. But often you get herniation of the contents of the orbit down into that trap door. Usually when it breaks, the weakest part is the little canal where the inferior orbital nerve runs. So when you make them look around, if they look up and only one eye goes up, that other one is probably entrapped. Right? They have a lot of edema, so it may not be that the muscle's stuck in the fracture, there just may be a lot of edema there, so you want to let them like heal for a little while, maybe 12 to 24 hours, and see if they still have the restricted gaze, and see if they can look up after that. Otherwise, they should go to the operating room. If on the CT, if you see that the muscles are stuck in the trapdoor, then they probably need to go to the operating room. Right? But if they have unresolving diplopia, they probably need to go and get relief. Here's what it looks like on CT. Again, you can see that the muscle, the inferior rectus muscle, is stuck in the trapdoor.
I just had a case that was interesting because the patient was like a pretty low mechanism. She got no signs of external trauma, and nothing. The only thing on the physical exam that was diplopia was just a little bit of pain with movement, and that's why we got the CT scan and we ended up being trapped.
Yeah, like I said, the mechanism is not really sure, but if you get just hit square in the globe, right in the middle, by the hydraulic theory, it'll just open up the globe. And the floor muscle, or the floor bones, and the medial wall are very, very thin. They call it lamina propria because it's like paper in the middle. So it's actually not uncommon for them to break with just minimal trauma. But, like you said, you have to have a high index of suspicion, and you have to do a good physical exam. If you didn't examine her well, she didn't have any external signs, you would have missed it if you didn't make her look up. So you have an 8-year-old female, she's Russian speaking, she's PET struck, she has positive LOC, she's tachycardic and moaning, so she really can't answer your questions. Alright? She's handling her secretions, but she has these large periorbital hematomas. When you look up her nose, her septum looks really strange to you. She has crepitus in her face, her cranial nerves are all intact, her vision's intact, but her face seems to move. So you work up, you do your ABCs, and here's what you see when you look. She has this large cherry red swelling on the inside of her nose. Right? This is the only one I've ever seen. There's got a picture of it luckily, but this is a septal hematoma. You have to drain it out, otherwise you're going to get cartilage destruction. Right? She gets the Pan-Man scan, she gets everything done because she's not talking, you don't know what's going on. You get your trauma consult, you get your face consult. You have to incise the septum, cut the mucosa, let the blood drain out, and then what you want to do is pack it so you hold the skin close to the cartilage so the septal hematoma doesn't reform. Here's what your CT looks like, right? A little bit of air in the soft tissue. Fractures going across here, going across here, going across here, going across here. So you know it's a Lafort type fracture because it involves the middle of the face, but you've got to figure out which one it is. So when you look at the Lafort fractures, type 1 goes from the jaw into the nose, and it's only the upper teeth that are off. Type 2 goes from the jaw into the eyes, into the orbits, across the nose, and out the other side. And then type 3 is way posterior. It goes to the back of the orbits and across the nose, so your whole entire face is sort of taken off from the rest of your skull. So she has the one through the nose, so you know it must be either a 2 or a 3. She's also got the posterior stuff, so therefore you know she must have a type 3 Lafort fracture. And remember, you don't have to have single types. You can have a type 1 on the left and type 2 on the right. They can be mixed as well. The one we had the other day was a type 1, type 2 mix. So Lafort, it's kind of interesting how this guy came up with these fractures. What it is, he took skulls, and he took them, and he attached them to a sled. And he put the sled on a track, and he dropped it from height. And depending on how high up the sled went, would depend on where it would break. The higher up the sled was dropped from, the more posterior the fracture pattern would occur. So lower heights for the type 2, type 1s, and higher heights for the type 3. So type 1 again, you have your horizontal maxillary fracture. It's just above the teeth. Only the hard palate is off the face, so only really the teeth should move when you kind of pull on. They usually have an open bite, and they'll have periospasms. Type 2 is a little higher up, right? It goes through the mandible, through the maxilla into the orbits, across the nose. So the bridge of the nose will be off as well as the teeth, but the rest of the face shouldn't move too much. Here's a nice type 2 that we saw just a couple years ago now, but you can see that it's through the orbits. Here's a recon of it, through here, and then down to here. Notice they're totally not always perfectly symmetrical. And then type 3s are craniofacial disjunction. Your whole entire face is off when you pull, the whole face will slide out. And while I understand it's kind of cool to see the face slide out, everybody shouldn't be testing this. You should do it once, see the face moves, and then nobody touches it again. Because every time you pull, you're going to break the clots, you're going to make it split more. Alright? This is what's called a dish face deformity. If you go on the internet and look for it, that's what you get. And that's it. I thank you for the oral surgery chiefs who got me all these pictures for my lecture. You guys have questions?
We're going to slowly, sorry.